landscape is going to change a lot. So it doesn't work here, so maybe it's better I move here from the computer. Sorry, I don't have the control of the screen.
I think the point.
No, it doesn't work. Look.
Okay.
Maybe it's closed.
It's not working.
No, it doesn't work. Look, I move here, but
بص هو بيقلب هنا بس مش بيقلب على
قلب كده. بيقلب عندك كده.
let's go again. Okay, perfect. We start. So this is actually the clinical treatment algorithm for HER2 positive disease according to ESMO. So if you have an HER2 positive breast cancer in the metastatic setting, the first line of treatment is still pertuzumab, trastuzumab, and chemotherapy. Because according to the data of Cleopatra, you have an overall survival benefit. In the second line setting, this is what was done before the data of Destiny Breast 03, so before having the data of overall survival. You have two different options, trastuzumab deruxtecan or tucatinib, trastuzumab and capecitabine, differentiating the second line according to active brain mets or stable brain mets, but you know better than me that trastuzumab deruxtecan demonstrated an activity also in active brain mets. So since we have an overall survival benefit in the second line setting, the new treatment algorithm will give only one option, that will be trastuzumab deruxtecan in the second line setting. So you know better than me that in the past you have only 10 to 15% of patients that were considered HER2 positive, and all the rest of the population was HER2 negative. And in the HER2 negative disease, you have no drug approved because trastuzumab and T-DM1 were not working in the HER2 negative population. The definition of HER2 negative was HER2 0 or HER2 1 plus and 2 plus with FISH non-amplified. And some studies have been done in this patient population. This study was the NSIBP B47, and in the title of the study there was exactly the term HER2 low. So patients with immunohistochemical 1 plus, 2 plus, and FISH non-amplified have been randomized in the adjuvant setting to receive docetaxel cyclophosphamide or AC followed by weekly paclitaxel plus or minus trastuzumab. And the primary endpoint was invasive disease-free survival. So in this trial, you have exactly the HER2 low population in the adjuvant setting. And you will see here, there was no benefit of adjuvant trastuzumab in the HER2 low population. That's why the approval of trastuzumab was only for HER2 3 plus or 2 plus with FISH amplified. Now we have several agents that can be tested in the HER2 low population, and specifically also with T-DM1 was done a study in the metastatic setting. This study was published on the JCO 10 years ago. And this was a study with T-DM1 in HER2 low population. Only one response was observed. So both trastuzumab and T-DM1 do not work in HER2 low population. Now we have the new antibody-drug conjugated. The antibody-drug conjugated of second generation have a very high drug-antibody ratio, can be also up to 7-8 molecule of chemotherapy. There is a cleavable linker and there is an overpayload. This is trastuzumab deruxtecan. The mechanism of action is very clear. You bind to the receptor on the cell surface. you have a mechanism of endocytosis, you release the chemotherapeutic agent within the cell, and finally, you have also a bystander effect. This was the original study for HER2 low and HER2 positive disease, the Destiny Breast 01, in which you have a dose escalation and then you have an expansion phase. And you will see here that since the beginning, there was an activity in HER2 low disease. And we have other agents exploring finally the activity in HER2 low. Trastuzumab duocarmazine is one, and another one is disitamab vedotin, with the minimal activity, not like the activity of trastuzumab deruxtecan. And this was a paper that we wrote in 2020. And finally here, we just highlighted that with the new agents, you may have an opportunity to activity also in HER2 low. In HER2 low, of course, you have a different population. You have HR positive that are close to 60%, and triple negative that are close to 40% of HER2 low. Is there a different biological entity? No, it is not, because if we analyze according to molecular subtype the HER2 low population, the majority of them are really luminal cancers, and there is absolutely no biological difference between HER2 positive, HER2 low, and HER2 zero. And looking at the data in terms of prognosis, the poor outcome is mainly driven in ER low population by less expression of estrogen receptor. So HER2 low is not a molecular entity, it's just a low expression of HER2 that can be a target for a new agent. Here we have all the studies that have been performed retrospectively. In the majority of the cases, there is no prognostic effect. And the Destiny Breast 04 clearly demonstrated that you can target HER2 low disease. The study was a prospective randomized trial for immunohistochemical 1+ and 2+, unresectable or metastatic. The majority of the patients received the previous chemotherapy, and patients have been randomized to trastuzumab deruxtecan versus treatment of physician choice. The primary endpoint was progression-free survival, secondary endpoint overall survival. What's about the patient? First, 60% of patients were HER2 1+ and 40% HER2 2+ with fission unamplified. 90% of them were HR positive. Only 58 patients were triple negative. The majority of them received the median of 2 prior lines of endocrine therapy and 1 chemotherapy. 70% of them received CDK4/6 inhibitors. Another important point is that Destiny Breast 04 is not an American trial. In North America have been included only 54 patients. The majority of the patients have been included in Europe, Israel, and Asia, not in the United States. This was a matter of discussion in the steering committee because, you know, if you include 70% of the patients, the first author should be from the country area where the trial was completed. This was the progression-free survival benefit. It's impressive in this population. Trastuzumab deruxtecan improved the median progression-free survival from 4 months to 10 months in the HR positive population, but improved also overall survival from 17 months to 23 months. Those are data unprecedented in this patient population. Interestingly, you have also an opportunity in the triple negative population. Even if 58 patients, there is an improvement in median progression-free survival and overall survival also in the triple negative population. And in terms of response, you have 52% response rate in HR positive disease and 50% in the triple negative disease. What's about subgroup analysis according to immunohistochemical 1+ and 2+ is exactly the same. So independently of level of expression over HER2, the median progression-free survival was 10 months, both in HR, in immunohistochemical 1+ and immunohistochemical 2+. Toxicity was very common, no new safety signal, gastrointestinal toxicity, hematological toxicity, and then ILD that account for finally 12% of the patient population included in the DESTINY-Breast04. According to this data, trastuzumab deruxtecan is a new option in the treatment of HER2-low metastatic breast cancer, both HR positive and HR negative. So in the United States, the drug is approved for both the subpopulation. Of course, we have many questions for HER2-low disease. First, the sequence of trastuzumab deruxtecan. Second, how to define an HER2-low. And third, we need to do biopsy every time in order to ascertain if you have an HER2-low disease. So, of course, in germinal BRCA mutant, even if HR positive, trastuzumab deruxtecan can be used also before a PARP inhibitor because there is an overall survival benefit. When to use it? According to the data of DESTINY-Breast04, following one line of chemotherapy, even if you have a very refractory patient to CDK4/6 inhibitors, you can consider to anticipate the use after CDK4/6 inhibitors. Consider that we have the DESTINY-Breast06 that will answer to this question. So the treatment algorithm should include all endocrine treatment strategies, a first line of chemotherapy, and then trastuzumab deruxtecan. What to do in triple-negative disease? Of course, you have an overall survival benefit, so TDX can be incorporated also in the triple-negative disease, but before or after sacituzumab govitecan. I would say if you have an HER2-low metastatic breast cancer, you can give a first-line chemotherapy, usually can be immunotherapy plus immunocheckpoint plus chemotherapy in PD-L1 positive, and then in the second line, you may consider the option or TDX or sacituzumab, and vice versa in the third line. The only scenario where you can give sacituzumab for sure is the HER2-0 population. Finally, we have new data with immunocheckpoint inhibitors, and you know that the Begonia trial demonstrated a synergy between TDX and durvalumab. So do we need to do biopsy? Yes, because HER2-low expression is a dynamic expression. So if you have HER2-0 in the primary tumor, you need to test in the metastatic setting, because in the majority of the cases, some HER2-low can be better expressed in the metastatic disease. So if you have HER2-0, the cancer can become HER2-low in the metastatic setting. So there is a dynamic expression, and you need to test and to recheck. So finally, what will happen in the future? Of course, first we have the DESTINY-Breast06. This trial completed the accrual this week. And this trial is designed also for HER2-0 population. So not only 1+ and 2+ with fission unamplified, but also HER2-0. And the majority of patients included in the DESTINY-Breast06 are HER2-0. And the design is trastuzumab deruxtecan versus investigator choice treatment. No patient in the DESTINY-Breast06 received the previous chemotherapy. So they are treated frontline with TDX. You will see the data in 1 year from now. Of course, in the future, the risk is that trastuzumab deruxtecan actually is approved for HER2-positive disease and for HER2-low, both triple-negative and HR positive. So this is really a blockbuster. Is a drug approved in any disease? So maybe in the future we need to better understand how can we maximize the benefit of this agent. But there is no other drug approved for all the subgroup of breast cancer, only trastuzumab deruxtecan. During San Antonio, we have the updated analysis of DESTINY-Breast03. This is a HER2-positive disease, trastuzumab deruxtecan versus T-DM1. This is the primary endpoint that was overall survival, and you will see it's impressive. There is an hazard ratio of 0.64, with the median overall survival that was not reached in the trastuzumab deruxtecan arm, but here you can see a huge difference, because we have a pre-planned analysis at 1 year and 2 years, and there is a clear benefit from trastuzumab deruxtecan. That's now because we have in the second line only TDX. The benefit of overall survival is in all the subgroup. Look, there is no single group with no benefit from TDX, and the progression-free survival is impressive. Finally, you have a confirmed median progression-free survival that is 6.8 months for T-DM1 in the second line and 28 months for trastuzumab deruxtecan. This PFS is better than the Cleopatra. In the Cleopatra trial that was first line, the median progression-free survival is 19.8 months in the first line. So you can anticipate what will happen with TDX in the first line. This is really an outstanding agent, but not because this is an AstraZeneca symposium, but because it's a very effective drug. Once you will use, you will understand the efficacy of this agent. What's about response rate? We have an overall clinical benefit rate of 90%, with many patients achieving a complete response and 57 patients with a partial response. So, I mean, here we can think about studies for oligometastatic disease in which maybe you can cure some patients. So it's really important to know this. What's about safety? Hematological toxicity, nausea and vomiting, and ILD. But in the DESTINY-Breast03, we have no fatal ILD. So within the steering committee, we increased awareness for patients and investigators, and we reduce it to 0 grade 4 and 5. So in conclusion, you would agree with me, trastuzumab deruxtecan is the new standard of care in the second-line setting. No option for other regimen because there is an overall survival benefit. And it's active also in brain mets. This is the subgroup analysis in DESTINY-Breast03 for patients with brain mets. 10 patients achieved the complete response on the brain lesions, and 13 patients a partial response. And then we have the DEBRA trial that explored the activity also in leptomeningeal disease. And here you will see the activity, the intracranial activity. Those patients have not been pretreated with radiation therapy. And this is another study that is the Tuxedo. Very few patients. This is the intracranial response in patients who never received radiation therapy. Finally, a few slides on management of toxicity. The most common toxicity are nausea and vomiting, ILD, and of course, alopecia potentially. For nausea and vomiting, you should consider trastuzumab deruxtecan as a moderate emetic risk group. So you should give HT3 plus dexamethasone as you premedicate for anthracycline or for other type of chemotherapy, and eventually olanzapine-based chemotherapy, olanzapine-based therapy. Don't forget that if you have on the first cycle nausea and vomiting and you premedicate on the second cycle, patient will tolerate perfectly the treatment. What to do for ILD? ILD, it's a very complicated side effect, so it's really important to recognize as soon as possible it. Of course, this is a typical example of ILD. You look, usually you have the appearance of this ground glass appearance on the lung. You should ask the patient to refer to you if there is cough or something like this, and you have to start as soon as possible steroidal treatment. So you stop trastuzumab deruxtecan and you start it with the immunosuppressive therapy, including steroids. And here we have really a summary of what you have to do. If you have a grade 1, you have a temporary discontinuation of the treatment, and you will give 0.5 milligram per kilo per day of prednisone or equivalent. For grade 2, you have to stop treatment and you increase to 1-2 milligram per day. You can rechallenge again if you have a grade 2, if you have complete resolution of lung interstitial disease. For grade 3 and 4, there is a permanent discontinuation of trastuzumab deruxtecan, unfortunately, and of course the dose of steroids can be higher. And this is again a summary. So in the new treatment algorithm, the new standard of care in the second-line HER2 positive disease will be trastuzumab deruxtecan, and there will be no more the option of tucatinib, capecitabine, and trastuzumab that will be moved in the third-line setting. So thank you very much, and I will be very happy to take questions.